Okay, let's really unpack this. What actually makes someone learn something? Especially when it's, really important stuff like managing their own health.
Right.
And why is just telling people things, well, why does it so often fall flat?
Mm-hmm.
Today, we are diving deep into the fundamental mechanics of learning. We're pulling from this really fascinating source chapter that kind of lays out the core principles, teaching, learning, especially for adults, and patient education.
Yeah, it's a great foundation.
Uses a healthcare example, right? Vascular patients, I think.
It does.
And it's our guide to understanding not just what info is key, but how that information can actually be, well, taken in, understood, and really used.
Yeah, acted upon.
Exactly.
Yeah.
So our mission here is to pull out the key insights on, like, learning theories, what really drives motivation, the different types of learning,
Which is weird.
why adults learn differently than kids, and, what barriers tend to pop up.
Yeah.
We want you to walk away with a much clearer picture of how this whole learning engine works.
Good.
Get ready to move beyond that old idea that learning is just, I don't know, filling a bucket with facts.
Definitely not.
We're going to explore things like the different domains of learning your head, your heart, and your hands.
That's a great way to put it.
And understand why teaching grown-ups, well, it needs a whole different playbook than teaching children.
Absolutely. And what's really striking in this source is how it hammers home that our role, especially in areas like health, isn't just about, dumping data on people.
Right.
It's about truly assisting them, helping them gain the knowledge and skills for themselves. And that means you have to tailor communication, you have to understand where they're coming from, and just accept that learning is, well, it's complicated, it's lifelong, and it happens within all these social and cultural contexts.
Okay, so to understand why just telling isn't enough, let's start where the source does. Foundational stuff, learning, and motivation theories.
The bedrock.
Yeah, and these aren't just like academic exercises. The chapter points out they give us actual guidelines for how to approach education. It pulls from psychology, sociology.
All the behavioral sciences, really. And the source highlights several specific theories that help explain why people might or might not take action, which is, pretty vital if you're trying to teach them something important.
Okay, lay them on us.
All right, first up, the health belief model. Basically, this model suggests that whether someone takes a health action, like, say, starting to exercise or taking meds regularly, it really depends heavily on their personal beliefs. Do they actually think they're at risk?
Okay.
Do they think the condition is serious? And maybe most importantly, do they believe the benefits of changing outweigh the hassle or the barriers?
So if those beliefs aren't there,
They're probably not going to act. Simple as that, according to this model.
makes sense. What's next?
Then you've got the Transtheoretical Model. Now, this one isn't so much about why people change, but more about when and how they move through making an intentional change. Think of it like stages of readiness.
Okay.
The source lists 5. Pre-contemplation, they're not even thinking about changing yet.
Right. Denial, maybe?
Could be. Then contemplation, they're starting to mull it over. Preparation, they're actually getting ready to try something. Action, they're doing it. And maintenance, they've stuck with the change for a while. And the key insight here, you see, is that you need to match your approach to the stage they're in.
Yeah.
You can't talk to someone in pre-contemplation like they're already in action.
That's a really practical point. Different messages for different stages.
Exactly. Then there's the social cognitive theory. This adds another layer. It emphasizes learning through, well, watching others, observation and imitation.
Monkey see, monkey do.
Sort of, but more sophisticated. People learn behaviors by seeing others do them and seeing what happens, the consequences. And we're most likely to copy people we identify with or, respect. Okay.
So seeing someone like you successfully managing their diabetes, for example, that can be a really powerful motivator and learning tool.
Yeah, I can see that. Modeling.
And finally, the source mentions the theory of reasoned action. This one suggests our intention to do something is shaped by our attitude towards it and what we think important people in our life, family, friends think we should do.
Social pressure or support.
Both, yeah. So if your doctor says change your diet, but your family keeps cooking the same old meals, that creates a conflict, right?
Yes.
And it affects your intention and your behavior.
So bringing this back to you, the listener, these aren't just abstract ideas. As the source shows, understanding these models helps us guess or at least understand why someone might seem, resistant to learning something vital. It's usually not just about missing information. It's tied up in their beliefs, their readiness stage, who they look up to, their social world. It gives us a basis for, well, empathy, and maybe a better strategy. Well said. And moving from those big theories, the source also zooms in on some core principles specifically about motivation.
Okay, what drives the learning?
Right. One principle is about the environment itself, the physical space, the social vibe. It can really focus attention or totally derail it.
Yeah, try learning in chaos.
Exactly. Another is that incentives can motivate learning, and this is key, internal motivation. That's the gold standard.
But driven from within.
Yeah, personal interest, curiosity, seeing the value for yourself, it lasts way longer and makes people more self-directed than just, external rewards or pressure.
That makes sense.
Learning is also most effective when the person feels ready, when they have that need to know, if they don't see why it matters now.
In one ear, out the other.
Pretty much. And lastly, how you organize the material matters. A confusing mess is discouraging. A clear, logical flow makes learning feel, well, doable.
That readiness point really hits home.
Yeah.
You can talk at someone all day, but if they don't feel that need right then,
Huh.
it's just background noise.
Precise.
Or the environment thing, trying to explain complex discharge instructions in a busy, noisy hospital corridor.
Forget it.
Compared to a quiet room where the patient feels, safe and can actually focus. Big difference.
Huge difference.
Okay, now let's get into something the source details that really broadens how we think about learning.
Yeah.
These 3 different domains. It shows learning isn't just happening in one place.
Exactly. The source breaks learning down into 3 kind of categories or areas.
Okay.
First, there's the cognitive domain. This is what most people automatically think of. Knowledge, facts, information, intellectual skills.
Head stuff.
Head stuff, yeah. And the source points out different levels here, from simple to complex. Lower down, you have knowledge, just recalling facts, listing things, and comprehension, understanding what it means, explaining it in your own words.
Okay, basic recall and understanding.
Then you move up to application, actually using that knowledge in a real situation, like demonstrating how to do something based on what you learned.
Putting it into practice.
Right. And these higher levels are so important. It's not enough for a patient to just know their medication dose. That's knowledge. They need to understand why they take it.
Right.
Comprehension, and be able to actually apply that to taking it correctly every single day. That's application. And there are even higher levels like analysis, synthesis, evaluation, deep thinking.
Got it. Cognitive domain. What else?
Then there's the affective domain. This one's often missed, but it's incredibly powerful. It's all about feelings, emotions, values, attitudes, beliefs.
Heart stuff.
Heart stuff, exactly. This includes stages like just receiving information, being willing to even listen, and then responding, actively participating, asking questions.
Getting involved.
Then higher levels like valuing, deciding something is actually important, committing to it, like deciding your health is worth the effort. And eventually, characterization, where these values become part of who you are and consistently guide what you do.
Wow.
Think about someone who knows smoking is bad for them, cognitive, but their attitude towards quitting is negative, or they don't truly value the long-term benefits enough yet.
Affective. Yeah, the feeling part gets in the way.
It's often the biggest barrier to change. Learning in this domain is absolutely critical.
Okay, cognitive, affective. What's the third?
The psychomotor domain. This is about physical skills, coordination, movement.
Hand stuff.
Hand stuff. Doing things. This covers everything from simple reflexes to really complex procedures. The stages here go from things like guided response, basically, copying a skill after you see it demonstrated, like mimicking how a nurse does an injection.
Okay, imitating.
To complex overt response, performing that skill smoothly, accurately, confidently, like giving yourself that injection correctly.
Becoming proficient.
Exactly. And even higher levels like adaptation, being able to tweak the skill for different situations, like adjusting how you wrap a bandage depending on the wound location, and even creating new movements or skills.
Wow, okay, that really paints a bigger picture, doesn't it?
Yeah.
Learning isn't just knowing facts in your head.
Not all.
It's how you feel about it. The relevance affective.
Mm-hmm.
And can you actually do something with it? Psychomotor. It makes you think when you're trying to learn something or teach someone. Am I hitting all 3? Or am I just dumping cognitive facts and ignoring the emotional side, or forgetting they need to actually practice the physical skill?
It's such a critical question. And it leads perfectly into another key distinction the source makes. Teaching kids versus teaching adults.
Right, they're not the same.
Definitely not.
So
The source uses the term pedagogy for teaching children and youth, and andragogy for the art and science of teaching adults. And those principles of andragogy are super relevant for patient education.
So what are the key differences for adults?
Well, adults are usually more autonomous, more self-directed learners than kids. They have a really strong need to know why they're learning something, the relevance, the immediate value. That need to know is huge.
Yeah, what's in it for me right now?
Yeah, pretty much. They also bring this huge reservoir of life experience and prior knowledge to the table, and that needs to be respected, tapped into, not just brushed aside.
Mm-hmm.
Adults also need a learning environment where they feel respected, accepted, safety is key, and their learning often shifts focus. Instead of subject-centered, like learning history because it's on the syllabus,
Right.
it becomes more problem-centered, like I need to learn how to manage my blood sugar because I have diabetes now.
Tackling a real-life issue.
Exactly. And finally, while external factors can motivate, those internal drivers wanting to improve, solve a problem, gain control, they're often much more powerful for adults.
That makes a ton of sense. You can't just treat an adult patient like a kid and say, do this because I said so.
Doesn't work.
They need the why, the connection to their life, their experience needs to count. It makes it much more of a partnership, doesn't it?
A collaboration, absolutely.
Okay, so let's pull this together and look at the direct application the source focuses on. Patient education. How does the chapter define that?
It defines it as the process where patients get the knowledge or skills through practice, study, instruction, basically, getting the tools they need for staying healthy, promoting wellness, or preventing illness.
Giving them the tools. I like that.
Yeah. And the goals mentioned in the source are pretty straightforward. Help the patient understand their condition better, increase their ability to stick with treatment plans, what they call compliance, develop the actual skills they need to manage their own care, and make sure the care involves their family or support system.
Okay, practical goals. And what about the principles for making it work effectively?
The source brings up some core principles, referencing Bartlett. First, teaching has to be relevant to that specific patient's needs and their situation.
Tailored.
Highly tailored. It must be adapted to their readiness, their background, their culture, their current understanding. You got to meet them where they are.
Crucial.
And the patient has to be actively involved, not just sitting there getting lectured. Involved in setting goals, figuring out how well they're learning.
Makes them take ownership.
Exactly. The environment needs to build trust, respect, acceptance. And if you're teaching a skill, you must provide chances to demonstrate it and for them to show you they can do it, that return demonstration.
Show me, then let me try.
That's the essence of psychomotor learning, yeah.
So patient education isn't just a quick lecture at discharge. It's a whole process, custom built for the person.
And the source really stresses that step one is understanding that person through a needs assessment.
Absolutely. A good needs assessment, like the one described in the chapter, looks at the whole picture. Their physical health, sure, but also, what do they already know? What are their demographics, age, family? Where are they in life? Who's their support system? What are their cultural or spiritual beliefs? And critically, how do they prefer to learn?
Learning styles.
Yeah, are they visual? Auditory? Do they need to do it to learn it? What methods do they like? You wouldn't teach a 75-year-old who likes reading printouts the same way you teach a 25-year-old who learns best from YouTube videos, right?
Good point. So you do the assessment. Then what? Then you move to planning. That means setting specific, realistic goals with the patient and figuring out exactly what content they need to reach those goals.
Okay, roadmap time.
Then implementation, the actual teaching. The source mentions different ways: one-on-one, group classes, prepping them before a procedure, demonstration, and different activities: discussions, role-playing, hands-on practice.
Lots of options.
And using various tools helps reach different learning styles: print materials for visual readers, videos for auditory visual, models for hands-on psychomotor learners, online stuff. It's about having a toolbox.
Right, like that ACE bandage example.
Exactly. For something like wrapping a leg properly for vascular issues, the source highlights that, showing them, then having them do it back while you watch demonstration with return demonstration. That's essential for locking in that psychomotor skill.
Makes sense. You got to practice it.
Yeah.
But how do you know if any of this actually worked?
Evaluation.
You got evaluation is key. Did the teaching stick? Was it the right approach? The source points to Kilpatrick's 4 levels, which are really useful. 4 levels. Okay.
Level 1 is just their reaction. Did you like the class? Basic satisfaction.
Smiley face sheets.
Kind of, yeah. Level 2 is measuring if they actually learned something, gained knowledge or skill, and if their attitude shifted. Did they understand and maybe start valuing it more?
Okay, learning happened.
Level 3 is the big one. Did their behavior actually change? Are they doing the thing you taught them
Consistently.
consistently?
The action step.
Right. And level 4 is the ultimate goal.
Yeah.
Did that behavior change lead to real benefits? Improved quality of life, better health outcomes, fewer complications.
So it's not just about passing a quiz, it's about real-world impact.
That's the aim. And evaluation methods can be asking questions, using surveys, or simply observing them perform the skill correctly.
That's a really powerful way to think about evaluation, moving beyond just, did they like it, to,
Mhm.
did it make a difference?
Definitely.
Now, let's be real. Anyone who's tried to learn something tough or teach someone, yeah, it's not always smooth sailing. The source acknowledges this, right?
Mhm.
It talks about challenges, barriers.
Oh, yeah, it's realistic. Lots of things can get in the way. The source categorizes them based on Beagley's work. You've got physiological barriers, things related to the body. Maybe age affects how fast someone processes info, or their overall health just leaves them with no energy to learn.
Physical limitations.
Then cognitive barriers, mental stuff, low reading level, making handouts useless, trouble with complex ideas, a mismatch between your teaching style and their learning style. Or maybe they just lack the basic background knowledge needed.
Okay, thinking and processing issues.
Then affective barriers, those emotional and attitude ones again. Low motivation, just not interested. High anxiety about their health, cultural beliefs that clash with medical advice.
Mhm.
Even side effects from meds making them feel lousy and unable to focus. Or maybe the learning environment just feels judgmental or unsafe.
Hard stuff getting in the way.
Exactly. And social barriers, relationships. Tension with family or staff, feeling intimidated by doctors. Challenges tied to their socioeconomic background or ethnicity.
Wow, that's a lot of potential roadblocks.
It is. The source does mention strategies to help involving the patient, assessing their style, going simple to complex, repetition, providing support. But it's also honest about limitations.
Things you can't easily fix.
Right. Patient factors, like maybe they just persistently lack understanding despite efforts, or they have zero access to resources, financial transport, or complex social problems. And sometimes, sadly, the disease itself is just too advanced or unmanageable no matter how good the education is.
That's a sobering reality check. Education isn't a magic wand.
It's not, but it's a powerful tool when used thoughtfully.
So we've taken this really deep dive, haven't we, into the mechanics of learning. We've looked at motivation theories, the different domains, head, heart, hands, the special needs of adult learners, how to apply it all in patient education step by step, and face those real-world barriers.
Mm-hmm.
And it really comes back to that core idea from the source. Effective education is way less about just transmitting facts
Much less.
and much more about assisting the learner on their own path.
Exactly. And understanding these dynamics, whether you're the teacher or the student trying to learn something tricky yourself, it's actually really empowering. It shows learning isn't just passive. It's active, it's dynamic, and there are levers you can pull.
Absolutely. Well, thank you for joining us on this deep dive into how we learn. It's been fascinating.
My pleasure. And maybe a final thought for you, the listener, to chew on, building on this material, knowing that learning involves your cognitive side, your affective side, and your psychomotor skills. How might you change your own strategy next time you tackle something new? A complex topic, a difficult skill, maybe even changing a stubborn habit in your own life. How would you approach it differently, thinking about all these pieces?